Proper patient positioning is as important as performing precision surgery with the Da Vinci system. Skin necrosis, neuropraxia, and compartment syndrome could be avoided with a well-prepared, reproducible team approach. After induction of anesthetic, our patient gets a caudal block consisting of clonidine, bupivacaine, and fentanyl. The skin is protected from intravenous and arterial lines. An air-filled glove is placed in between the patient's fingers. Special care is taken in wrapping the hands and arms. Orthoband is used that includes the hands up to the axilla. A green jelly or profile pad is wrapped over the hand and elbow for further protection. This usually requires 2 people to safely apply. A larger profile pad is then folded under the patient. Maximum contact to the yellow jelly or action pad is required to prevent the patient slipping once in the steep Trendelenburg position. A further 6-inch wide folded sheet is used to tuck the arm in on the side of the patient. Care should be taken to ensure that this sheet is loosely fitted. All name bands are individually protected. The legs are covered with orthoband from the ankles to the thighs. Note: no anti-embolism stockings that could potentially impede circulation in Trendelenburg position. Long floatrons are secured into position. A specially modified bear hugger covers the patient's chest and limbs. The eyes are protected. A thermal hat prevents further heat loss. An L-bar is fixed into position to protect the face and airway from the assistant's leaning elbow. The steep Trendelenburg position of 40 degrees is assumed to ensure no patient movement. Note: no shoulder pads or strapping. Further padding is used between the patient and the yellow fins. The legs are secured in the yellow fins, covered with a bear hugger, and the floatrons are connected. The hip should be flexed at 40 degrees and the knees at 110 degrees. Care should be taken to ensure adequate space between the calf and the yellow fins to prevent direct pressure. After port placement, the patient is placed in the Trendelenburg position while the surgeon visualizes the bowel content moving out of the pelvis. The robot is docked. Postoperatively, the patient is flattened as soon as the robot arms are disconnected. At the end, the calves are checked to ensure that they remain soft. Anti-embolism stockings and floatrons are then applied. Finally, the upper limbs are also inspected. By not using shoulder pads, we avoid brachial plexus injuries. Through this technique, we have significantly reduced our incidence of neuropraxia at Lister Hospital.